Good evening to everybody. On behalf of IAP TNSC, I welcome one and all for this wonderful teaching program. In fact, today is actually 40th postgraduate teaching program today. And I welcome one and all. First, we'll start with the pediatrician prayer by our Dr. Gopal Subramaniam, Treasurer, IAP TNSC.
Thank you, sir. We'll start today's PG teaching program by pediatrician's prayer. குழந்தை மருத்துவ நிறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும், நோயிடன் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வுமாக எல்லா குழந்தைகளுக்கும் அவர்களின் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதர்களா என்று இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும் நல்லவற்றை உள்வாங்கவும் மாற்ற முடியாதவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். நன்றி.
Thank you, Dr. Gopal. And now I welcome our beloved President IAP TNSC, Dr. Ismail sir, to give a felicitation.
Thank you, Dr. Rajendran, Dr. Gopal Subramaniam, respected honorable judges of this program, the chairperson, Dr. former director, Dr. Swaminathan, the moderators of the today's program, Dr. Suma from Bangalore and Dr. Deepthi from CMC Vellore. Of course, this being a very useful and a wonderful program being designed for the postgraduate and the undergraduate by the IAP. Of course, the variety of teaching and by the good teachers, eminent teachers are participating. You will have the opportunity, rare opportunity to get such teachers for having a good discussion in your subjects, and I wish you all a happy learning. Thank you.
Yeah, thank you, sir. It's now it's my duty to welcome our chairperson, Dr. G. Swaminathan sir, professor and head of the department of pediatrics and former director Madurai Medical College. Currently is head of the department of pediatrics, Trichy SRM Medical College Hospital and Research Center. I welcome Dr. Swaminathan sir.
Thank you, sir. Thank you, sir.
Yeah, now I welcome my one of the best outgoing postgraduate, Dr. Suma TL, and she is a consultant pediatric hemato-oncologist at HCG Cancer Center and Bangalore. I welcome Dr. Suma. Yeah, I welcome Dr.
Thank you, sir.
Now I welcome Deepthi, Associate Professor of Pediatric Hemato-Oncology, Christian Medical College, Vellore. Now I welcome today's presenter, Dr. Rajkumar from SRM Medical College, Dr. TP Haridharani, Dr. Vidya. So I welcome all the judges, Dr. Balashankar from Madurai Medical College, Dr. Elirasi, Director from ICH Chennai, Dr. Janani Shankar, KKCT, and Dr. PRC sir, SRMC Chennai, Dr. Srinivasan sir, Pondicherry, and I welcome all the delegates all over India. And so now we can start today's program. And now I request Dr. Swaminathan to tell few words. Dr. Rajkumar, you can start sharing your slides.
Yes, sir. Sure. No problem, sir. We can start. I thank the IAP Tamil Nadu, Dr. Ismail sir and Dr. Rajendran sir and Dr. Gopal sir for giving us an opportunity to present the case and share our knowledge also along with IAP and other postgraduates of various medical colleges. And I thank all the professors who have taken the time to come here and engage yourself in the discussion. And always I thank the moderator, Dr. Suma and Deepthi, for having accepted to moderate this session. Thank you so much, sir.
Yeah, now I welcome Dr. Suma to tell few words.
Thank you so much, sir. That was a very kind introduction. I have worked with Dr. Rajendran between 2008 and 2010, and he's such a wonderful teacher. And I completely owe my pediatrics to my training in KMCH. That has been the turning point in my life. Thank you so much, sir, for making me a part of this academic discussion.
Thank you, Dr. Suma. Now I welcome Dr. Deepthi.
Thank you for giving me this opportunity. Actually, I'm new to this panel. I've not met many of you, but yeah, I've been in Vellore for all my life from undergraduate and post-graduation. Then I've been I've done my DM in pediatric oncology in RCC Trivandrum. After that, I've been working in Vellore itself as a pediatric oncologist. I really thank the organizers and sir for giving me this opportunity, and I wish the presenting PGs all the best for this evening.
Thank you, ma'am.
Thank you, Dipti. And Dr. Rajkumar, you can proceed. Yeah.
Yes, sir.
Good evening to one and all present here. I am going to present the case of a 11-year-old female child from Perambalur admitted with the chief complaints of abdominal pain for 3 days, fever for 2 days, vomiting for 2 days, high colored urine for 2 days. The child was apparently normal 3 days back, presented with history of abdominal pain for 3 days, which was insidious in onset and progressive in nature, intermittent, generalized dull-aching type of pain, lasting for 15 minutes, not radiating, relieved spontaneously, no aggravating factor. The history of vomiting for 2 days, 5 to 6 episodes, non-projectile vomiting. Usually it occurs after the food intake, contains mainly the food particles, not blood or bile stain. The history of fever for high grade and intermittent type of fever, relieved by paracetamol. The interfebrile period child was dull looking, not associated with chills and rigor, no diurnal variation. The history of high colored urine for 2 days, 4 to 5 episodes per day, bright in color, always associated with burning maturation, no history of reduced urine output, and no history of pain during maturation. On history of loss of appetite for past 3 days, and history of generalized myalgia, musculoskeletal pain present, maximum observed in the ribcage, mainly during the inspiration. The no history of cough, cold, and sore throat, no history of generalized edema and facial puffiness, no history of skin rashes, no history of headache, neck stiffness, blurring of vision, and seizure, no history of heartburns and discomfort in the epigastric region, no history of breathlessness, palpitation, syncope, and pedal edema, no history of other bleeding manifestations like melena, bleeding gums, and epistaxis, no history of loose stool. No history of jaundice, no history of extreme tiredness or lethargy, no history of recurrent UTI or LRI, no history of recent travel, no history of any drug intake, no history of swelling over the major or minor joints. On past history, history of low-grade fever on and off 2 weeks back for 2 days, patient improved without any medications, associated with loss of appetite and loss of weight, no history of previous hospitalization, no history of blood transfusion, no history of contact with COVID-19 or tuberculosis. On going to antenatal history, she was a first child born out of non-consanguineous marriage, booked and immunized, iron and folic acid taken, antenatal scan done normal, no maternal complications. From birth history, it is a full-term normal vaginal delivery at Perambalur GH, cried immediately after birth. The birth weight was 2.7 kg, no history of NICU admission, postnatal period was uneventful. On developmental history, the developmentally normal child studying 6th standard, average scholastic performance. On nutrition history, the child taking mixed diet, no history of raw milk intake. By 24 hours recall method, the calorie deficit of 290 kilocalories and protein deficit of 2 grams. On immunization history, immunized up to age according to the national immunization schedule, not received any optional vaccines. And family history and socioeconomic history, it's a non-consanguineous marriage, no similar illness in the family members. According to modified Kupasamy scale, child belonging to lower middle class family. In the summary of the history, the 11 years female child admitted with complaints of abdominal pain, vomiting, hematuria, fever with loss of appetite, and generalized myalgia, mainly the musculoskeletal pain, with the possibilities of urinary tract infection, acute appendicitis, post-streptococcal glomerular nephritis, typhoid, malaria, dengue, acute leukemia, lymphoma. On general examination, child looking 11 years old girl, well built and well nourished, ambulant.
Sir, we can discuss with history, sir. My moderators can enlighten on how to. Is there anything he has to add in the summary and history? Hello, moderator, ma'am.
Okay, so Dr. Rajkumar.
Yes, ma'am.
So this is a 11-year-old girl, isn't it?
Yes,
So
ma'am.
she has a sudden history of fever, a lot of constitutional symptoms, and sudden onset of hematuria.
Yes, ma'am.
What was the first thing that came into your mind?
UTI, ma'am. It is a present with abdominal pain with the GE symptoms and high colored urine. First, we have to suspect UTI, ma'am.
So, I mean, so when there is a history of UTI, what was the other thing that you were looking for? I mean, did you ask for any past history of similar episodes?
Yes, ma'am. I asked for the past history, no past history in the urinary tract infection, recurrent urinary tract infection in the past. Because it's a female child, it's the most common cause for the UTI in female child adolescent age group, ma'am, nearing to that.
Okay. So when you were asking for other bleeding symptoms in your history, what was the diagnosis that was going on in your mind? What were you looking at?
So possibility to rule out the complications of dengue manifestations, ma'am. Any other bleeding disorders, ma'am. And in case of any rashes, impetigo, to rule out post-streptococcal glomerulonephritis, and in rashes to rule out Hinans-Collin purpura like that, ma'am.
So is PSGN common in this age group?
No, ma'am. Less likely, ma'am. Only school-going children can. More likely to get.
So you mentioned HSP. So what kind of rash would you expect in HSP?
Painless, palpable purpura will be present, ma'am.
Okay, and what is the type of distribution that you would look for in HSP?
So mainly in the peripheries will be present, ma'am. In the dorsum of hand or legs, in the flexor aspect of the forearm.
What is the classical distribution of rash in HSP?
Classic. Macropapillary type of rash, ma'am.
It's generally beneath the umbilicus, isn't it?
Okay.
So they have a lot of rashes on the back, buttocks area.
Yes, ma'am. Mainly in the buttock region.
Yes. So what is the relationship? I mean, it's a very short history, isn't it? Were you suspecting HSP in this child?
No, ma'am. It's a rare possibilities only, ma'am.
Okay.
Mr. Rajkumar, you presented the history well and covered most of the points.
Okay, ma'am. Thank you, ma'am.
Yeah, when you come to differentials, instead of just putting as points this, you could, just say it's an acute history. So I would keep infectious as first possibility and name the 1, 2, 3, 4 infections. Then say rheumatological or immunological causes, and then hematolymphoid malignancies. You can classify and maybe put like that. So the same, like what you said, it's an acute history. Maybe UTI could be, some other infection also, an enteric infection. Though it's acute, dengue. Though the period is short, still infection is the first thing. But you could classify and put what are the infections that you're thinking of, and then if you classify your differentials, it will be more easy for us to, like, the examiners will understand that you've understood what you're trying to tell.
Okay, sure.
Yeah.
Okay. Mainly the infections, the typhoid, malaria is dengue, UTI also included in the infection category. In case of malignancy, it can be acute leukemia or lymphoma.
Sorry, usually do not interrupt moderators. Can you just go to the slides one by one, your symptom presentation? Yeah, next, please. Okay, yeah. How severe was the abdominal pain?
So child can able to tolerate, sir, pain but not interfering with the day-to-day activity or sleep. The pain characteristic is a dull aching type and generalized only, sir.
So all over the abdomen, there was no flank pain or anything.
No, sir. It generalized to all the 9 quadrants, sir.
Right from the beginning, it was a generalized pain.
Yes, sir. Yes, sir. Yes, sir.
Okay. And was there any relief spontaneously? That means when the child lies down, it will get relieved or what?
Sir, not specific to any relieving factor, sir. It's a.
So what is the clue from the abdominal pain for you? So where do you think it is originating from?
It mainly inflammations are suspected because all the 9 quadrants, it's a generalized type, sir. That's why suspecting mainly inflammation etiology, sir.
Do you think it is originating from the liver or kidney or spleen or pancreas or intestine or peritoneum or lymph nodes? Will you get any clue from the type of abdominal pain?
No, sir. It can no. Since it is a generalized pain, we can't able to locate any specific organ, sir, in this history, sir.
Probably what does rules out? Can you tell at least that?
Yes, sir. If it is a not radiating pain, we can rule out renal calculi, sir. Then no aggravating factors by.
No, it is not a unilateral pain. No, it is a generalized pain.
Yes, sir. Yes, sir. General. Yes, sir.
Conditions you will get unilateral pain.
If it is any located to the any loin region, particularly localized pain, we can suspect renal calculi, sir. In right, if.
Rajkumar, what made you to think it is a? You said it's appendicitis. What made you to think about appendicitis? Can it be due to peritonitis or mesenteric adenosis?
No, sir. It is mainly presented with the more of the GE symptoms like vomiting, abdominal pain. So we generalized pain over the abdomen. We suspected first acute appendicitis, sir.
Okay. Was there any pain localized to right iliac fossa specifically?
No, sir. No, sir. There is no localized pain in right iliac fossa, or it's not radiating to the umbilicus also, sir.
So what do you think this pain? Was it a pain due to peritonitis or can it be a pain due to diffuse mesenteric adenitis? How can you differentiate these two from the history of pain?
Sorry, in case of peritonitis, child will be toxic look, sir, but this child is not that much toxic, sir. Then not affecting the day-to-day activities also, sir, with that pain. In a short history, we can't able to commit with the peritonitis, sir.
Okay, with the history that there is some yellow discoloration or high colored urine or red colored urine.
Yes, sir.
Can you localize it to with the abdominal pain? Can you think of whether it is originating from the liver or kidney? Is there any clue for you?
Sir, it can be, sir. It can be, sir.
Can you connect these symptoms?
Yes, sir. It can be originated from liver also, sir, and kidney also, sir.
Kidney means it's not unilateral. From both kidneys, it should arise, no?
Yes, sir. Possibilities are there, sir.
Okay. What else? Any other thought in your mind? See, we are just looking at the symptom analysis.
Yes,
because
sir.
many of the examiners at the end of your history ask you to analyze the symptoms and what are your differentials.
Okay, sir.
And they will want you to justify when you are telling. And the symptom analysis is one of the very good the logical approach.
Okay,
To
sir.
a particular system and diagnosis.
Okay.
So are you getting any clue from this symptoms? You're not obviously getting anything from the abdominal pain. Am I right?
Okay, sir. Sir, since it is a abdominal pain with vomiting and hematuria, considered with the female child, more possibility is a complicated UTI first, sir.
Urinary tract infection.
Yes,
at
sir.
this, age 11 years, no?
Yes, sir. Yes, sir.
Okay, it is possible. Not that it is not possible.
Okay, sir.
But generally, they get a flank pain if it is originating from the kidney.
Okay, sir.
If you are thinking of a urinary tract infection in such a child, are you
Okay.
thinking of upper urinary tract or a lower urinary tract?
Sir, it's a lower urinary. Lower urinary tract, sir, because it is a bright red in color, sir. That's why it is a lower urinary tract, sir.
We get so much of constitutional symptoms in lower urinary tract: fever, vomiting.
Sir, vomiting, abdominal pain associated with chills and rigor, fever.
See, mainly, I mean, more than your diagnosis, you will be mainly questioned regarding your approach.
Okay, sir.
How you look at the symptoms, how you analyze, okay, whether you are having a systematic approach. That is what has to be looked at, because many a times,
Okay,
we
sir.
have to make some diagnosis from the symptoms itself.
Okay, sir. Yes,
So
sir.
if at all, it should be upper urinary tract, isn't it? Because the child has toxic manifestation. I mean, the child has got some constitutional symptoms, and the pain is not suprapubic.
Yes,
It's
sir.
more of a generalized, according to you. Okay.
It's a
You're not saying that it is UTI, but if
Okay.
at all, it is upper urinary tract infection.
It's a possibility of acute pyelonephritis also, sir.
Is it? Yeah, we don't know. Okay. I mean, because you are bringing this possibility of urinary tract infection, we are just discussing.
Okay, sir. Okay, sir.
Sir, I think the moderator should take over. As Dr. Jenny has said, please put
Yes.
your this thing to the
See, Dr. Rajkumar, what sir is trying to get from you is because it's a very short history, isn't it?
Yes, ma'am.
Somebody needed hospitalization and medical attention within 3 days of onset of symptoms.
Okay.
So what does it tell you? I mean, you have a combination of fever, abdominal pain, which is not localizing to any, particular visceral organ. You have vomiting, you have high-grade fever, and hematuria. So with the constellation of these symptoms, what is the first thing that comes into your mind? Because it's a very short history. So somebody is really sick, and this child is really sick and needed an admission within 3 days. So the first and foremost thing, either a medical cause or a surgical cause. So in medical causes, what is the first thing that comes to your mind? UTI you mentioned.
Yes, yes, ma'am. UTI.
Yeah, UTI. So what is the next most common cause that you're thinking about?
Dengue, ma'am.
Dengue. Have you? How common is hematuria in dengue when they present? I mean, within first 3 days of fever, is it that common?
It is a less likely, ma'am. But if considering infective etiology, we can put the dengue as a first possibility, ma'am.
Yes, next to UTI, isn't
Yes,
it?
ma'am. Yes, ma'am.
So you also mentioned typhoid and malaria.
Yes,
We
ma'am.
know in malaria, bleeding manifestations are quite common, but in typhoid, if a child were to have a bleeding manifestation, as you're suggesting, so what is the basic, pathology that is happening that has caused the hematuria in typhoid? If you were to say that this child is probably having typhoid.
So in typhoid, the hematuria is less likely only, ma'am.
Okay.
Why I put that typhoid in this history means mainly the symptoms are most of that it's a GI symptoms only, ma'am. Abdominal pain, vomiting. That's why I put the diagnosis enteric fever in infective etiology, ma'am, next to dengue.
Yeah. So again, see, it's a very short history, 3 days history of symptoms. Would you think of typhoid first? No.
No, ma'am.
I don't think it, even if it was a complicated enteric fever,
Okay.
is this a common presentation that we see in ER?
No, ma'am.
It's not common, isn't it? So you're basically trying to rule out, one by one in your list that you have made. You have to try to rule out one by one. So because the next step is you want to look for the signs of what is happening in your mind. Or you're thinking, okay, this is the most probable diagnosis. When you start examining the child, those are the similar signs you want to look for in the child, isn't it?
Yes,
So
ma'am.
that is the main reason you have to rule out one by one as you go on taking the history.
Okay.
Okay. So are you among the viral infections, you mentioned few bacterial. So among the
Yes.
viral infections, what are the more common causes of for this kind of a presentation?
So hepatitis can present, ma'am. Acute hepatitis can present with abdominal pain and vomiting, ma'am, with fever.
Okay. Hematuria?
Hematuria is very less, ma'am. Very less possibilities in, mostly unlikely in acute hepatitis, ma'am.
Sometimes autoimmune hemolytic anemia can happen with hepatitis, but I'm not sure they would present within 3 days of onset of symptoms, but that can also be there. It's very, very less likely.
Okay, ma'am.
So based on your symptoms of fever, abdominal pain, and vomiting, you think it could be hepatitis?
Yes, ma'am.
The viral reason. So what are the other viruses that can present like this with hematuria, fever, abdominal pain, vomiting, and child being very sick, requiring hospitalization?
In viral etiology,
What viral infections can cause problems with urinary tract?
adenovirus, ma'am.
Yes, adenovirus can cause. So what are the other clinical features the child would have had if it was a adenoviral infection?
Adenovirus. Loose stools will be present, ma'am. Presented with loose stool. Respiratory tract also involved, ma'am. Respiratory symptoms will be present, ma'am.
Yes, yes, which is not there in your child, isn't it?
Yes, ma'am.
So isolated involvement of the urinary bladder or the urinary tract without any respiratory symptoms or even eye congestion, redness of the eye, nothing is there in your child, isn't it?
Yes, ma'am.
And sometimes these infections can also have involvement of other children in the family. There can be family history also, isn't
Yes,
it?
ma'am. Family history will be
Somebody
possible.
else in the family can also be affected. So that history is not there.
Yes, ma'am.
And so that also moves down in your list. So
Okay.
more common causes at this point in time for you is UTI, and then you're looking for any other causes on
Infective
your
etiology.
list.
Infective etiologies, dengue, then typhoid.
Yes. So in the surgical causes, as you had made a list, appendicitis just discussed with you. These
Yes.
children will be more toxic, isn't it? They have
Yes.
an order of presentation. In
Yes,
them,
ma'am.
the fever is not the first symptom. Pain and
Yes, ma'am.
vomiting are
Abdominal pain,
first,
vomiting, followed by
and
fever.
followed by fever. So you have to look at chronology of symptoms there. So surgical problems have more, especially if it's appendicitis, they have pain, vomiting first, and then progressing into fever. And then, as the appendicitis goes on through its stages, then they'll start having different symptoms according to whether, if it's a perforated appendix, then they'll have more symptoms and then they become more toxic. They can even have up to the level of hypotension and requiring resuscitation.
Okay.
So that again, do you think that is likely in this patient?
Less likely only, ma'am. Because the chronological order of the symptoms present, we suspected the appendicitis as the first possibility in surgical cause, ma'am. Because presented with abdominal pain, vomiting, that's why we suggest.
So do you think your patient is disproportionately tired compared to her symptomatology?
No, ma'am, not.
It's only 3 days of history, isn't it? Do you think,
Yes, ma'am.
You have mentioned somewhere that she was having generalized myalgia?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Isn't it?
Yes, ma'am.
So it's causing even pain during inspiration.
Yes, ma'am.
So what is the first thing that comes to your mind when you think of the the mentioned symptomatology and musculoskeletal pain of this type?
In dengue also we can present with the musculoskeletal pain, ma'am. Then we have to go for any leukemias.
Okay.
Leukemia we can suspect, ma'am.
Any myeloid-related disorders?
Yes, ma'am. Myeloproliferative disorders.
Okay.
can go on with the examination, I think.
Okay, sure.
Sorry to interrupt. Which infections do you get very severe musculoskeletal pain? Infections other than dengue?
In chikungunya, sir.
Good. Chikungunya, anything else?
Uh,
Even in leptospirosis you can get. That's not, of course, viral.
Leptospirosis. Okay. Sir.
Leptospirosis you can get.
Okay.
And you said something about the urine. Is it red colored or high colored, or is there any? Can you just explain that?
Bright red in color, sir. It always associated with burning maturation.
Oh.
No, yes, sir.
Okay, there is burning maturation also.
Yes, sir. Yes, sir.
Okay,
No,
sorry, I missed that. Right. Okay.
Okay.
Were there any clots or anything caused?
No, sir. No, sir. No, sir. Not associated with clots, sir. It's a fresh bleeds.
Okay. Were there any loin to groin pain or anything?
No, sir. No, sir. No, sir. No history of pain during maturation. Also, sir.
I mean, the bright red urine and you said there is dysuria. While passing urine, she's having severe pain.
Yes, ma'am.
Actually localizes the whole thing to her bladder, actually. Cystitis comes first in the thing,
Okay.
cystitis. But you said there is severe pain while passing, burning maturation is there, then you're saying there is no pain during maturation. You're
Yes,
actually
sir.
predicting what you said, actually. I think you got confused there. So
No,
there
ma'am.
is,
What I'm telling to implies, ma'am.
Contradictory, no?
Yes, ma'am. The pain refers to it's a loin or like that, ma'am. To rule out that calculate. For that, I mentioned that pain
Actually,
during.
where is the pain when the child is passing urine?
Sir, this
In
case.
the introitus or in the urethra or in the suprapubic region or in the abdomen? Where is the pain?
Urethra, sir. Urethra. Sir.
Okay.
So was there any urgency or difficulty to hold the act of
No,
micturition?
ma'am. No, ma'am. No, ma'am. No history.
So that's again going against urinary bladder, isn't it?
Yes, ma'am.
Okay.
Shall I proceed with the examination, ma'am? On general examination, child is sick-looking, ambulant, sick-looking 11 years old girl, well-built, well-nourished, ambulant, conscious, oriented, afebrile, mild pallor present, sternal tenderness present, ecchymotic patch about 3 cross 2 centimeter in size, irregular in shape, in ventral aspects of left forearm, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy, no pedal edema or no neurocutaneous markers noticed, hydration fair, not tachypnea. On vitals, the temperature 97 degree Fahrenheit measured in axilla by digital thermometer, the pulse rate 118 beats per minute, regular in rhythm, normal in volume, no specific characters, no radio-radial delay, no radio-femoral delay, felt in all peripheral vessels. The respiratory rate 22 per minute, regular thoraco-abdominal type, BP 110/70 mmHg measured in left upper limb in supine position, falls between 50 to 90th centile for age, gender and height, SpO2 98% on room air. On anthropometry, weight 42 kg between the 50 to 75th centile, then height 142 centimeter, 25th to 50th centile, and BMI 20.83 implies the child is overweight. On head to toe examination, head appears normal in size, no dysmorphic faces, hair appears normal in color and texture, eyes pallor present, no evidence of icterus or signs of vitamin A deficiency and cataract, ear, nose and throat normal, no tonsillitis or pharyngitis or no cheilosis, skin appears to be normal except ecchymotic patch in the left upper limb, no joint swelling in both major and minor joints. On systemic examination, on abdomen, inspection, shape normal, flanks free, umbilicus in midline, movement of abdomen, all quadrants equally moves with respiration. No distended veins, scars and sinus, no visible gastric or intestinal peristaltic movement, skin over the abdomen normal, hernial orifices free, external genitalia normal. On palpation, it's a soft, diffusely tender in all quadrants. The tender hepatomegaly 2 centimeter below the right costal margin in mid-clavicular line, rounded edge, smooth surface, soft in consistency, no pulsation. The spleen 2 centimeter palpable in the left costal margin in mid-clavicular line, tender, smooth surface, firm in consistency, tip of the spleen facing the right iliac fossa, no renal angle fullness or tenderness. On percussion, liver dullness started from 5th intercostal space, the liver span of about 13 centimeter, no shifting dullness, no fluid thrill, dull sign negative. Auscultation, bowel sound heard, no bruit noticed. On other system, the cardiovascular system S1, S2 heard in normal intensity, no murmur. In respiratory system, bilateral normal vesicular bed sound heard, no added sounds. On central nervous system, higher mental function normal, tone, power and reflex normal, no cranial nerve involvement, fundus examination normal, no signs of meningeal irritation, no focal neurological deficit. On the summary of both the history and examination, the 11 years female child came with complaints of abdominal pain, vomiting, hematuria and fever with loss of appetite, bony pain in sternal region with pallor, ecchymotic patch and hepatosplenomegaly. With the possibilities of typhoid, leptospirosis, dengue, malaria, and acute leukemia.
So this child on physical examination, general physical examination, you've noticed she has another bleeding patch, isn't it?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
And in history, she has hematuria.
Yes, ma'am.
So what did it alert you about?
When, by considering along with the sternal tenderness, we can suspect that leukemia with bleeding manifestation, ma'am. Without a sternal tenderness, it can be a dengue manifestations also, ma'am.
Okay.
Then bleeding disorders, ma'am, can be possibilities.
So is sternal tenderness a normal thing that you look for, or for any specific reason you looked for it in this child?
No, ma'am. There is a history of musculoskeletal pain. The child implies that mainly pain in the rib cage during the inspiration, and we did the.
So you looked for it.
Yes, sir. Yes, ma'am. We on general examination we looked for the sternal tenderness.
Child is having pallor and some bleeding manifestations in terms of ecchymotic patch and then hematuria. Then you're also on examination, your positive examination findings were a hepatosplenomegaly.
Yes,
all these places, what do you think is involved for this child? What is going wrong? Not the etiology as to what caused it, which system is involved?
It's systemic involvement, ma'am. Systemic involvement, ma'am. No specific systems involvement. No specific system, ma'am. It's a more likely possibility of hematology, ma'am. On general,
some
reticuloendothelial system, isn't it?
Yeah.
Yes. Yes.
Yeah. So what all conditions cause reticuloendothelial system involvement with such a short history?
Leukemias, ma'am. Lymphoma.
Like this, but because it's a rare leukemia, it's rarer. We have more common causes that can present like this than leukemia. So definitely leukemia you could think of. Maybe the child has leukemia.
Okay.
But what are the other things that you would think?
Lymphomas.
I mean, you already named them. I'm just again asking you to just name them properly so that you put them in order.
In infective etiology, malaria, typhoid, dengue.
Malaria, typhoid are a little long duration.
Okay, ma'am.
Maybe dengue might be a shorter, but still 3 days history. You could say, like when you could say it could be dengue, but still the duration is less. So you state your differential and you say
Okay.
points for and points against.
Okay.
See, no case fits into a typical case ever.
Okay.
But you could say that this is infections being a most common cause. I would consider dengue as a possibility, but however, 3-day history seems to be a little shorter. Maybe the history was not accurate. Something you could say for and against. So could you say some three?
Yes,
most
ma'am.
common
Sure.
differences
Yes, ma'am. Sure.
and defend for and against?
Yes, ma'am. For in typhoid with the for fever, mainly GI symptoms involved, and hepatosplenomegaly will be present, ma'am. For the against is it's a rare manifestation of ecchymotic patches and hematuria, rare in typhoid, ma'am. In leptospirosis, it's a history of favoring the fever. Hepatosplenomegaly, the icterus is not necessary, ma'am. It can be present with the anictic stage also, ma'am, in leptospirosis. In dengue, it's for is a fever. Hepatosplenomegaly, it's a ecchymotic patch. Ecchymotic patch and hematuria is more suggestive of dengue, ma'am. In malaria, fever will be present, ma'am. Hepatosplenomegaly, compared to liver, the spleen will be more prominent, and that hematuria will be less likely in late complications of malaria, ma'am. But for is the musculoskeletal pain is present in malaria, ma'am. In acute leukemia, the most of the features is for only, ma'am. It is a low-grade fever with the short. It can be short history, less than 2 weeks also, ma'am. Hepatosplenomegaly will be present. Bony tenderness is there, and bleeding disorder like ecchymotic patches is there, ma'am. No against for leukemia in this case history, ma'am.
Rajkumar, the history is only 3 days.
Yes, yes, sir.
But you said something about the child is getting fever off and on for some time.
Yes, sir. In past history, sir, there will be fever, sir. 2 weeks.
How many months? Or
yes,
how
sir.
many weeks?
2 weeks before, sir. The duration of 2 to 3 days only, sir. It's a low-grade fever only, sir.
Only once, sir.
Sir.
Only once.
Yes, sir. Only once, sir. Once, sir.
Not repeated fever.
No, sir. No, sir. They not taken any medications also, sir. The mother is not able to recognize her at that time also, sir.
Right.
When
but you also mentioned about some loss of weight.
No, not associated with loss of.
Not associated.
Yes, sir. Yes, sir.
Okay. Okay. Right. So they did not have any idea that the child was not well 3 days ago.
Yes, sir.
Absolutely running, playing child 3 days ago.
Yes, sir. Yes, sir.
But this history of fever on and off 2 weeks back, they have not received any medication. Did you ask whether they received any like a native medicine or some herbal supplements from home or something?
No, ma'am. Actually, what the Frank is the child not able to recognize that episode also, ma'am. When we recall the history, then mother suspiciously he revealed that history, ma'am. There is a possibilities of fever at that time. We didn't recognize it like that. We recall the history, ma'am.
Because many times, sometimes they might give a homemade some herbal medicine or something which might have certain steroids which might mask the presentation of a leukemia if it was there.
No, ma'am. No, ma'am. Not like that, ma'am.
For a child with history of 3 days, why were you looking for a contact with TB?
So less likely only, ma'am, tuberculosis, but contact history we have to rule out, ma'am. Since we are in India, it's a more common tuberculosis in India.
You asked it as a routine, or was it of some significance in this child?
Routine only, ma'am.
So you have mentioned in the fever that the child was still dull looking in between the febrile episodes. So what information that did that give you?
The patient is a toxic, ma'am. It implies as a toxic, ma'am. If interfebrile period, it is a mainly significant difference that bacterial and viral, ma'am. The interfebrile period, the child will be active in viral etiology, but in systemic illnesses also, the child will be dull looking in the interfebrile period. like leukemias, any other the rheumatological conditions like juvenile rheumatoid arthritis, sogia, like that. Interfebrile period, the child will be dull only.
Dull looking.
Yes.
Basically a systemic infection, severe systemic whatever disease, infections or
Yes, ma'am.
surgical or malignant.
Yes, ma'am. That's what I'm telling.
So what would you do next for this child? How would you proceed after this?
I'm going to investigation. Start with the complete blood count, ma'am. First, we rule out from the infective causes from the complete blood count, ma'am. Then we have to do peripheral smear, ma'am, for malaria, ma'am. Then urine routine, LFT, RFT for the multi-system involvement. For leukemia, we have to plan for bone marrow aspiration, ma'am.
In complete blood count, what are the various things that you're looking for?
Yes, ma'am.
And if you want to tell the pathologist to look for, what are the various things that you would like to tell the pathologist to look? So you can tell the complete blood picture. What are the various things that you're expecting to find here? And
yes, ma'am. In more than 2 cell line or pancytopenia, we have to first bicytopenia or pancytopenia have to rule out, ma'am. For specific infection, I will imply the certain cell line, ma'am. The leukocytosis mainly present in leptospirosis, ma'am. For leukopenia, present in dengue and enteric fever. Then thrombocytopenia will be present in dengue, scrub typhus, typhoid, leptospirosis, and some complicated malaria, ma'am. That eosinopenia also present in enteric fever, ma'am. The thrombocytosis, if present, means mainly implies that inflammations, ma'am, in systemic involvements with inflammation.
are you presenting the child's investigations also, or?
No, ma'am. No, ma'am.
So, and peripheral smear, you're asking the doctor to look at, or the pathologist to look at. So what are you telling the pathologist to look for?
You have to first look for the blast cells, ma'am, and malaria, ma'am. Blast cells for leukemia and malarial parasites, ma'am, for malaria in peripherals, ma'am.
See, the information, what Dr. Deepti is trying to ask is, so you're going to call the pathologist, you have a sick looking child with a very short history, has 2 places where there are bleeding symptoms, one from the urine and one from the skin.
Yes.
She has no lymphadenopathy, but she has hepatosplenomegaly. You are either looking for infections or you're looking at some sort of acute leukemia.
Okay.
Okay.
Yes,
so when you tell the pathologist you want a complete hemogram, you also mentioned that she's having mild pallor.
Yes,
isn't it?
Yes,
so because it's a probably a short history, the amount of blood loss that has occurred from through urine has not yet caused a decompensation and pushed her into mild, moderate to severe pallor. That is what we have understood from your clinical examination, isn't it? You mentioned only mild pallor, so but the child is actually losing probably frank blood along with her urine.
Okay.
That is what I have understood from your history presentation. So you want to tell the doctor that you're looking at a child who can have anemia, a child who can have thrombocytopenia, and probably requires urgent need for transfusion.
Yes, ma'am.
So you want to alert your blood bank that be ready. I'm going to order for PRBC and or platelet products, and you do not know what the WBC count can be.
Okay.
It can be normal, low, or high. That you do not know. Whether depending on what the etiology is, the WBC count can change, and of course the differential count also will change accordingly.
Okay, ma'am.
So with CBC and peripheral smear, you're looking for, you think your child has a low HP, low platelet, significant enough to cause bleeding. So that means something at the range of less than 50
Yes.
less than 30,000, which is a critical value,
Okay.
isn't it?
Yes.
So,
ma'am.
and because your child is sick and running temperature, each episode of fever can push her further into lower and lower platelet counts. So these are the things you will think of when you order a CBC and peripheral smear.
Okay. ma'am.
Okay.
Okay. ma'am.
Any other tests that you would like to do to find out the reason for bleeding?
Coagulogram we can do, ma'am. BTCT, PT, APTT, INR.
Many times, sick children with severe infections like dengue and all will have a deranged PT-APTT, or even in acute looks and certain types of leukemias, you might have a DIC-like picture. So you might want to look at that also to not only correct the anemia and platelets, you might want to correct the coagulation. I mean, if it is involved, any of the bleeding parameters to be corrected.
Okay. ma'am.
And what else you would what are the investigations in the first so you've taken your complete blood counts,
count.
coagulation parameters and bleeding time, clotting time, everything. Then what else? What other tests would you order?
Urine routine, ma'am. RFT, LFT. Then blood cultures, ma'am. We can send. So definitive for that enteric fever. Then antibody for the leptospirosis, dengue. Then
Rajkumar, the fever is only 3 days. Do you expect the antibodies?
sir.
Fever is only 3 days, no?
Okay, sir. Yes, sir. Fever for 3 days.
So do you expect the antibodies the first week?
Yes, it's sir. In dengue, we can expect the NS1 antigen from the day.
NS1.
Yes, sir.
That is agreed.
Yes,
that
sir.
is agreed. But the
Yes.
leptospirosis or strep typhus, generally, if you're lucky, sometimes you may get positive. The history is not reliable.
Okay, sir.
But a negative doesn't rule out.
Yes, sir. After 1 week of fever only we can get, sir. Okay.
Kumar, are you getting what Dr. Deepthi is asking? See, if you're thinking leukemia, you have done some this thing for the infections. Now you will have to treat this child. So what other parameters you will assess in this child?
In CRP we can
start some treatment, no?
Yes, sir. We can done a
So
CRP.
what other things you will look at? You said LFT, RFT, all the CBC culture. What else?
Then CRP we can done, sir, to look the trend of the improvement.
What can be an emergency in a child like this? Let us say it's leukemia, and within 3 days the child has become so sick. So there is something emergencies you should be prepared for. No?
We can
That's
done
why, am I right,
ultrasound.
Dr. Deepthi? That's what you are asking?
I'm asking for the various biochemical parameters that can
Exactly.
go wrong.
Yeah.
And what would you look for, and how, like, how would you be prepared? Like you might be not in a hematological center also, but even if you're you might need to refer the child also with acute look, but you should find out certain things before you refer to stabilize the child. So what are the initial
serum electrolytes we can done?
What are the various parameters that you would look at?
Serum electrolytes we can look.
What are the various electrolytes and what are the various biochemical things?
Sodium, potassium, ma'am. Calcium, phosphorus. In case of tumor lysis syndrome, it is a medical emergency. In hyperphosphatemia, hyperkalemia, hypocalcemia. For that, we can do electrolytes.
Anything else?
Uric
Uric acid.
Uric acid. hyperuricemia. Yes.
So this child had hematuria, has hematuria, isn't it?
Yes, ma'am.
So what are you expecting anything to be wrong with her creatinine?
No, ma'am. No, ma'am. RFT is normal, ma'am, for this child.
The pathologist told you that the total count for this child is 2 lakhs, 90% blasts in the peripheral smear.
Okay, ma'am.
Platelets are 10,000, and sodium is 132, potassium is 5.5, calcium is 7, phosphorus is around 10 milligram per deciliter, and uric acid is around 10 milligram per deciliter. So what are the various things? How would you approach? And the hemoglobin is 4 grams. So we'll start with how you would manage with all the hematological parameters. Then we'll come to the biochemical parameters. So hemoglobin is 4. Total count is 2 lakhs, and platelets is 10,000. So what would you do now?
First, I'm going to start with the PRBC transfusion, ma'am, to stabilize the baby first.
You said the child is not in any congestive cardiac failure.
Okay.
What is the emergency to stabilize the hemoglobin? She's not requiring any oxygen. Why do you want to transfuse packed cells first?
Ma'am, it is an ongoing process with the severe anemia and bleeding manifestations is more likely, ma'am, if the platelet count is very low.
When there is anemia and thrombocytopenia, what Dr. Deepti is trying to ask is which one would you correct first?
And also hyperleukocytosis. Total count is
and there is a
very high count is there. So
what do you want to treat first? What does high WBC count tell you? That the viscosity of blood has gone up, isn't it?
To hydrate the child, hydration first.
Yeah.
Then alkalization of the urine.
No, you want to first secure an IV line and start hydration while you order the blood products that you need.
Okay.
Isn't it? The blood is not going to come immediately, isn't it? You need to cross match, inform the lab. Sometimes the same blood group might not be there. So you need time to arrange all these things.
Okay.
So you look at the order of things that you can do. So first thing you can start is hydration, because the blood viscosity has gone up. The WBC count is too high.
Okay.
So what we want to know from you is when there is hyperleukocytosis, what are the organs at risk? And you want those organs to be saved from any damage. So what are the things that you can prevent by starting appropriate hydration?
Kidney, heart, then
Heart,
brain, mainly the end organs, ma'am.
yeah. So which organs are you most worried about? Respiratory, brain, isn't it? Things can go wrong with brain when there is hyperleukocytosis accompanied by thrombocytopenia. The child can have a bleed,
Yes, ma'am.
isn't it? So you want to prevent that. So you want to start hydration while you order platelets.
Okay.
Okay. The next organ that is at risk, as you mentioned, is kidney.
Okay.
The next organ would be lungs.
Okay.
Lot of things can go wrong if children have hyperleukocytosis and have a thrombocytopenia. So especially lung is also at risk.
Okay.
So you want to protect all these organs first by starting hydration.
Okay.
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 And so the next thing that you want quicker than PRBC would be platelets. You want to first rise the platelets. You want to stop her bleeding.
Okay.
you want to bring her platelet count to a sufficient level, after which you can transfuse blood.
Okay.
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 So when you're giving hydration, you should be also what should you be careful about?
We have to look for the fluid overload, ma'am. Overhydration also leads to pulmonary edema.
So dicey situation here. She's got low hemoglobin and at the same time high cons. You have to hydrate, at the same time you have to look at fluid. So very careful fluid. You should start hydration. Ideally, we
Leads
would
to
start. Yeah,
congestive cardiac failure also.
Yeah, we would start at 3 liter per meter square, but in this child, we'll be very cautious. But we definitely have to start hydration because that is the first thing that needs to be done. But very carefully monitor for features of congestive cardiac failure.
Okay.
So yeah, we have started hydration for the child, and she's passing urine adequately, and we've arranged for blood products, transfused her, and all that. In the meantime, your biochemical parameters have come.
Okay, ma'am.
That initial time before starting hydration itself. So as I said, sodium was 132, potassium was 5.5 milligram per deciliter, calcium was 7.2, phosphorus was 10, and uric acid is also 10 milligram per deciliter. So, and what would you do now? What is the child having at the moment? And what would you?
Suspected of tumor lysis syndrome, ma'am. It is a hyperuricemia will be present, ma'am. So we have to give the soda bicarbonate. We'll give, ma'am.
How would you correct hyperuricemia? I mean, not soda bica, right? Soda bica?
For hyperuricemia, alkalization of the urine we have to done, ma'am.
Long ago, they used to do alkalinization of urine, but now it's not recommended. You don't do that.
Ma'am, excuse me, ma'am, we can proceed with Rash buricase or allopurinol as a treatment if it is a case of tumor lysis syndrome, ma'am.
Yes. Yeah, allopurinol you could add as orally or as buricase.
As an IV medication, we can add.
Yeah.
300 mg per kg per meter square dose. Allopurinol.
Okay. Then anyway, what are the parameters for reducing the hyperuricemia, which you already done?
We have already rehydrated the baby with the IV fluids, ma'am. So it will again reduce the hyperuricemia along with the Rash buricase or allopurinol, which we add, ma'am.
So in this whole thing, which parameter would you attack in this whole gamut of abnormal biochemical parameters which I've said? Which one is the most dangerous?
Hyperkalemia, ma'am, will be more dangerous.
Hyperuricemia will be the more dangerous aspect, ma'am, because it will lead to neuropathy, nephropathy, ma'am.
It will take some time, but hyperkalemia will cause sudden death, and
Okay.
so potassium is something which you need to correct very aggressively and immediately. How would you correct hyperkalemia?
Ma'am,
Suppose potassium is 6 for this child. What would you do?
we can directly start insulin infusion also, ma'am.
What are the other things that you can do other than that? Yeah, definitely insulin dextrose. Then
Salbutamol nebulization we can give, ma'am.
For immediate correction, we can proceed with calcium gluconate, ma'am, as an IV administration.
Just like how you would correct a hyperkalemia in any of your pediatric child, no? So we have to stabilize the heart first. So calcium gluconate has to be given, and then
Or membrane stabilizer.
yes. Anything else?
Or membrane stabilizer, calcium gluconate. For intracellular shifting the potassium, insulin we have to give. And as salbutamol also for intracellular shifting the potassium.
Yeah. So now the other parameters are there, no? Here, child's calcium is 6 and phosphorus is 10 milligram per deciliter. What would you do?
In hypocalcemia, can give calcium gluconate, ma'am. Hypocalcemia is corrected by calcium gluconate also, ma'am.
So if all the other parameters have gone up in tumor lysis, why only calcium has gone down?
It's deposited in the vessels, ma'am. Vessel wall.
Calcium binds to phosphorus and forms calcium phosphate. So calcium is actually going down because phosphorus is going up in the blood. So would you want to correct that calcium, and when would you want to correct that calcium?
First, we have to correct that hyperphosphatemia, ma'am, because that hyperphosphatemia will suppress the calcium, ma'am. That's why the calcium is also low. So first, we have to correct the hyperphosphatemia. After checking the repeated calcium, if it is low, also we will correct the calcium, ma'am.
Secondary hypocalcemia, isn't it?
Yes, ma'am.
Secondary to hyperphosphatemia.
Yes, ma'am.
Yeah, that would not need immediate correction. Once you correct hypophosphatemia, if it still persists and is causing clinically, problems, then you correct it.
Okay.
Okay.
Yes.
And this is one conducted orally.
Yes, ma'am.
These children don't need any, emergency IV calcium correction. You can your hyperphosphatemia treatment and slowly correct the calcium orally. They will be stable enough for that.
Okay.
Okay. And when do you actually correct hypocalcemia, as Dr. Deepthi was asking? What other dyselectrolytemia are you looking at? Magnesium?
Yes, ma'am. Magnesium. Yes,
if the calcium is not getting corrected despite doing all the sorting out all other biochemical problems, if it's still not getting corrected, then you look at levels of magnesium. And then you correct hypomagnesemia and then
Okay.
Like Dr. Suma said, we don't correct calcium unless they're symptomatic, like either they have tetany or seizures. How much lowers the calcium? We don't give IV calcium because it will further precipitate the calcium phosphate crystals formation and then further worsening of the renal failure. So orally we could give because that also acts as the phosphate binder.
Okay.
Definitely IV calcium we would avoid. So now based on the peripheral blood picture and the biochemical parameters, we come to a diagnosis that this child is having acute leukemia, hyperleukocytosis, tumor lysis syndrome, and all that.
Okay.
We have stabilized the child, we have hydrated the child, transfused the child, and try to correct all the tumor lysis parameters. All that. Now, next, what would you do?
To go for the invasive procedures, ma'am. Bone marrow aspiration we can do, ma'am. To diagnose any specific type, leukemia or lymphoma, acute lymphoid leukemia or acute myeloid leukemia, to classify the specific type of leukemia, ma'am.
See, when the count is 2 lakhs, isn't it?
Yes, ma'am.
Most of the information you will be able to get on peripheral blood sample itself.
Okay, ma'am.
Okay. So
Okay.
when the count is high, there's a high chance that even the blast percentage, whatever type of leukemia,
Okay,
that
ma'am.
there's a higher chance that blasts also will be high in number.
Okay.
A good pathologist will be able to tell you based on the morphology itself that what type of leukemia you're looking at.
Okay.
Okay. So, so given your history, you have had bleeding from in the urine, there is skin bleed, and now your pathologist has said acute leukemia. So which leukemia are you most likely to diagnose in this patient?
ALL, ma'am. Acute lymphoid leukemia, ma'am.
Okay. Why would you say that?
The childhood age group, start from the age group, it's more common, ma'am, leukemia.
The
Most
common cancer
pediatric.
in children is acute leukemia.
Yes, ma'am. Yes, ma'am. In pediatric age group.
Yeah, in that acute leukemias, the most common diagnosis that we make is acute lymphoblastic leukemia. So by nature of incidence, you're more likely to diagnose ALL in this child. But given, so that ALL can also have thrombocytopenia causing bleeding manifestations. Say if this child were to have AML, and there are, I'm sure you would have read up, so there are, you know, the FAB classification types of AML. So which is the most common AML you're likely to diagnose in this child?
AML M3, ma'am.
So in case, so what we do generally is when, you know, it's not very common, but it would be better to add fibrinogen levels just to be on the safer side, because every investigation takes 2 to 4 hours to get back to you. So if you add fibrinogen levels and D-dimer levels in your coagulogram, so you will get the complete picture. Okay. So you can have a fair idea that, okay, there is no consumptive coagulopathy. It is a pure thrombocytopenia related problem. Okay. So if there is consumptive coagulopathy, you have to get prepared for a lot of other things, isn't it? You will have to get more types of blood products from the blood bank. Okay. To ask them to keep for cryo or FFP, I mean, you know, depending on what is available. Okay. So if you had those 2 investigations under your coagulogram, your it'll almost be a complete investigation. Okay.
Okay. So actually, the diagnosing AML M3 is also a emergency, other than the hyperleukocytosis, tumor lysis. This type of leukemia needs to be immediately even if you don't have any facilities, just a peripheral smear itself will tell you that it could be AML M3. So what would you find in AML M3? Actually, that's what I was initially asking to ask you would ask the pathologist to look for blast, and in blast specifically, what are you looking for to tell you that it could be AML M3?
No idea, ma'am.
How are ALL blasts different from AML blasts? AML blasts, what is seen in peripheral picture, peripheral smear?
Lymphocyte blast cells will be present in ALL, ma'am. In AML, it's a myeloid picture will be present, ma'am.
So what is the feature of a myeloid blast commonly? I mean, not everybody might, or not all AMLs might have, but what if it is there, then you know it is an AML. What is that? We would have read it long time in MBBS pathology. Have you heard of the oil rods?
Granules.
Or rods.
Oil rods.
Yeah, oil rods are there, no? The eosinophilic granules. Yeah. So in an AML M3, there'll be a lot of oil rods, like a pack of oil rods, like a faggot. It's called a faggot cell, where it's not like one or even if one oil rod is there, it suggests of AML. But in an APML or AML M3, you'll have like a stack of oil rods called the faggot cell or a cigar, like a cigar pack. So it's called that. If it is that is there, if you don't need any confirmation, you need to, I mean, you definitely do other confirmation tests, but definitely you would start specific treatment and life-saving treatment for the child immediately wherever you are.
Okay.
Would you know how to differentiate a myeloblast from a lymphoblast? Or any of your friends can help? Okay, so I'm presuming this child turned out to be leukemia in your hospital. Was this child the
Yes.
eventual diagnosis leukemia? Okay.
Yes, ma'am.
Did you go to the pathology lab and look at the smear?
Yes, ma'am.
In myeloblast, excuse me, ma'am.
Yeah.
In myeloblast, the size of the myeloblast will be pretty larger than the lymphoblast, ma'am. And the nucleoli present in the myeloblast will be higher. It will be around 5 to 6 than in the lymphoblast, ma'am. The nucleoli will be higher, and as I've already mentioned, myeloblast will have an oil rods present along with the scanty cytoplasm. And in the lymphoblast, it will be a very scanty cytoplasm, ma'am, compared to the myeloblast.
This is the picture we got, ma'am.
Other than the blast that you can see, obviously there. So what is the most striking thing in that smear to you?
It's a hypersegmented neutrophil.
Okay. Something is absent, no?
Yes, ma'am. Platelets.
Yeah. So there are no platelets. This is a peripheral smear?
Yes, ma'am.
Okay.
Many times it might be difficult to differentiate between a myeloblast and lymphoblast clinically, though there are so many, we have so many differences. Definitely an OROD is that we can make. Any other tests that cytochemical tests or stains that can be done to differentiate between a myeloblast and a lymphoblast, which we would have read in our pathology before? Simple stains.
EDT stain, ma'am. PAP stain.
Which stain would be positive in a myeloblast, and which stain would be positive in a lymphoblast?
That Kala stain will be positive in a lymphoblast. PAP stain.
I'm not talking about flow cytometric markers or thing like common peripheral smear to stain, no? Any stains that you know? Myeloperoxidase, MPO.
Yes, ma'am.
Yeah, that should be positive in
Myeloblast.
Yeah. And have you heard
Periodic acid PA stain will be positive in lymphoblast.
Yeah. EDT also.
Okay, so you've had a child, 11-year-old. She has bicytopenia with hyperleukocytosis, and you have evidence of tumor lysis syndrome, which you are tackling. So do you want to refer the child to somebody else, or do you want to go one step further and diagnose a little more things about this patient?
I want to refer only, ma'am, for the hemato-oncologist.
Say this was a different scenario, okay? There was no hyperleukocytosis. TC was normal.
Okay, ma'am.
There were no blasts on the smear.
Okay.
You said mild pallor, isn't it? So say the hemoglobin was 9.
Okay.
Platelet count was 15,000.
Okay.
But peripheral smear is just showing some lymphoid predominance, just 60%. and no abnormal cells on the peripheral smear, then what would you do?
Can be a lymphoma, ma'am.
What percentage of leukemia patients will have blasts? They may not have blasts in the peripheral smear, but when you do bone marrow aspiration and further tests, they turn out to be leukemia. Because not all leukemia patients will have blasts in the peripheral blood, isn't it?
Yes, ma'am.
So what percentage of them do not have blasts in the peripheral smear and don't make your job easy?
15%, ma'am.
So you can't still refer the patient to a hemato-oncologist, isn't it? There are
Yes,
no
ma'am.
blasts in the smear.
Yes, ma'am. 10 to 15%.
But still there is some problem with your child.
Yes, ma'am.
Okay, so what? So
10 to
around
10 to
up to
15.
20% patients do not have blasts. There is no spillover in these patients. But there will be an ongoing process in their bone marrow.
Okay.
So that would make bone marrow aspiration and biopsy a mandatory investigation.
Okay.
Okay. So in an 11-year-old child, what are your preferred sites for aspiration?
Mainly iliac, ma'am. Iliac crest.
Do you want to do, see, there are certain places where we advise bilateral iliac crest aspiration and biopsies. In leukemia, do you want to do it on both sides?
No, ma'am.
Why wouldn't you want to do it on both sides?
Don't know, ma'am.
It's not a focal involvement, isn't it, of marrow? It's a diffuse
Of the bone
involvement of
marrow
marrow.
involvement.
Yeah, so wherever you put the needle, you are going to get some diagnosis in this patient. So there are certain conditions, they can be malignant or non-malignant conditions, which it can involve marrow in focal way. Okay, in those patients, bilateral aspiration and biopsy becomes important.
In case of any secondaries.
Yeah. So in this patient, one site aspiration biopsy would be sufficient for you.
Enough.
Okay.
Okay, ma'am.
So once the aspirate is done, the first drawn sample ideally should be sent for smear.
Yes, ma'am.
And further immunophenotyping tests for characterizing the type of leukemia. Okay, the first drawn sample should be taken.
Okay.
Okay, so when you can diagnose most of the things on aspiration, why do you need a biopsy?
For further confirmation, ma'am.
Okay, so basically you would need a biopsy to get the cellularity of the marrow. You want to see if it's a packed marrow, normal marrow, or a hypocellular marrow.
Okay.
In some patients who present with acute leukemia to you the first time, especially children who are less than 10 years of age, they can have a predisposing condition where they've had hypocellular marrow, which has gone undiagnosed for a very long time. And their first visit to you will be with leukemia.
Okay, ma'am.
Okay, so those patients, when the pathologist calls you the first diagnostic marrow, if he tells you it's a hypocellular marrow, but it's acute leukemia, you want to look for some predisposing conditions which have led to the manifestation of acute leukemia. So what are the conditions, benign hematological conditions, which can present as leukemia at a later time? You mentioned neurocutaneous markers, no?
Yes, ma'am.
Okay.
So
recent
NF1.
Yeah, caffeolae
Yes, ma'am.
spots.
Ataxia.
Say if this patient was 6 years old.
Okay.
Had numerous caffeolae spots on the body, which has not caused any problem to the child. There's no dysmorphism.
Okay.
Okay. And the child has presented to you first time with leukemia. So what are the things you would look for in this patient? Or what history would you ask in this patient?
I have to ask for the running in the any family members history, family history, ma'am.
Yeah, so first degree relative affected, first degree relative you want to know, isn't it?
Yes, ma'am.
So is the next sibling affected or the parent affected? You want to have a history of similar neurocutaneous markers in the family.
Okay, ma'am.
Okay, so say the child had some physical dysmorphism also along with Caffulet spots, and now the child has leukemia and has come to you. So what is the first thing that comes to your mind?
Down syndrome, ma'am.
Down syndrome have Caffulet spots?
No, ma'am. No, ma'am.
What's the most common inherited marrow failure syndrome, which presents with physical dysmorphism, Caffulet spots, and at some point in their lifetime can present with acute leukemia?
Bloom syndrome, ma'am.
Fanconi's anemia can be presented, no?
Yes, Fanconi's can present like that, isn't it? They're short-statured. Their phenotype is classical. They can have some skeletal abnormalities. They can have multiple Caffulet spots, and they would have gone undiagnosed for a very long time. And their first presentation to you might be with bicytopenia and a normal or low WBC count. And you do a marrow and you find a hypercellular marrow with leukemia. So the underlying cause in that child would be an inherited bone marrow failure syndrome, which predisposed the child to have a leukemia, isn't it?
Okay.
Okay.
So physical examination helps in that way. So if you are having some neurocutaneous markers, it will help you manage the child better. So you have a background history of something predisposing it to leukemia. So you have to be very cautious while you subject the child to chemotherapy drugs. That's the main reason we hematologists look for neurocutaneous markers. Okay.
Okay, sure.
What is the another genetic condition where leukemias are very common?
Genetic conditions.
Ataxia telangiectasia can be presented with leukemia, no?
Yeah, but more common than that. Yeah, ataxia telangiectasia can have leukemias, especially T cell ALLs, which is a genetic condition which is known to have develop a lot of leukemias frequently.
Down syndrome, ma'am.
Yeah,
Down syndrome, Klinefelter, Lee-Froman syndrome.
Down syndrome commonly you see children might develop. I mean, it's more common than the rest of the other genetic problems. So in Down syndrome, what leukemias do you see?
ALL only, ma'am.
AML is more common in Down syndrome.
So
ALL is more common. AML is more specific to Down syndrome.
Yeah. So ALL is common across all pediatrics, even in Downs also, but the proportion if you take, it will be 80% ALL and 20% AML in a normal pediatric, whereas in a Downs children it will be 60% ALL and 40 will be AML. So AML percentage is more, but the commonest leukemia still is ALL, except in the neonatal period where they might have what do you see in neonatal period what could you see in a neonatal period in a Down syndrome which is associated with a lymphoid pathology?
No idea.
I mean, it's many times missed also. Children with Downs can have something called transient abnormal myelopoiesis, where actually,
isn't it?
yeah. So it's like I mean, leukemia only, but need not be always treated. It can be as not so severe, but could be sometimes severe. It is like an AML only. You need not know that, but if you should be aware that children can present with something called TAM in a neonatal period, which can resolve on its own or later on progress on to develop AMLs.
Okay.
So we have at presentation for an acute leukemia, we have thought about hyperleukocytosis, tumor lysis. So what are the, and APML is an emergency, AML M3, because they'll have coagulopathy. We have to look at fibrinogen, correct the, bleeding parameters and all that, and start the specific treatment quickly. Any other emergency child with hematolymphoid malignancy can present with, which you should be careful and look out for?
Yes, ma'am. Superior vena cava obstruction syndrome, then superior mediastinal syndrome, then febrile neutropenia. These are the remaining medical emergencies, ma'am.
In a superior mediastinal syndrome, how would a child present? And what would you do? How would you manage the child?
It's facial congestion, it's dilated veins in the neck. Then cough will be symptoms, ma'am. Breathing difficulties.
Suppose the child Dr. Suma has mentioned to you about in the X-ray is having a large mediastinal mass and having the superior mediastinal syndrome, like what you said, having facial engorgement and something. What are the precautions that you would like? But still, there are no blasts. How would you proceed?
You have to keep the patient with head and elevation. There is no IV cannulation in the upper limb.
Why no IV cannulation in the upper limb? Very good.
Will progress, ma'am. Progress the congestion, then overload, ma'am.
Already superior vena cava is obstructed. You won't want to give some more fluid through the superior vena cava. Upper limb is draining. Is drained via the superior vena cava. So you don't want it will worsen the congestion symptoms, right?
Then avoid sedation, ma'am.
Yeah. So when you're doing a marrow, you wouldn't want to sedate the child at any cost.
That's all.
This child didn't have any lymphadenopathy, isn't it? Otherwise, the discussion would have taken a different turn. Even if this child has a short history,
Yes,
some mild panner, anticipating thrombocytopenia, hepatosplenomegaly, and say this child had lymphadenopathy and significant lymphadenopathy. So that would have made our job easier, isn't it?
Yes, ma'am.
Yeah. So when there is, so what percentage of children in acute leukemia do not, have or do not have lymphadenopathy?
Rarely with lymphadenopathy in leukemias, ma'am. The lymphadenopathy usually associated with lymphoma only, ma'am. Approximately less than 10%, ma'am.
In your mind, what is the difference between lymphoma and leukemia? What do you think is the difference?
From age group wise, ma'am, that
No, you have a thought process which is telling you that this is not lymphoma and this is leukemia. So what is making you think like that?
the lymphadenopathy will be predominant symptom, ma'am, in lymphoma.
Okay.
That in leukemia is less than 10% only lymphadenopathy will be present, ma'am.
Okay. So, so what I would want to know is, can leukemias present or evolve from lymphomas?
Yes, ma'am.
So what type of lymphomas go on to become leukemias? See, when you say lymphoma, you mean to say that there is no marrow involvement, isn't it?
Yes,
That's
ma'am.
the main thing that you are saying. That's the main difference in your mind.
Yes, ma'am.
So that means it's a pathologic or pathogenic involvement of lymph nodes, peripheral lymph nodes. That is what we can see. Because if it's retroperitoneal, mediastinal, you do not know when you examine the child, isn't it? You know only that there is peripheral significant lymphadenopathy. And I'm sure you know for different areas what is significant lymphadenopathy, isn't it? For cervical, it is what, for axillary, it is what, for inguinal, epitrochlear, depending on different anatomical locations. So when you say lymphoma, that means in your mind, that means it has not yet involved the marrow.
Yes, ma'am.
Once it involves marrow, it becomes leukemia. So lymphomas can start in the lymph nodes and then involve the bone marrow and then become leukemia. Then you do not call them lymphomas, you just call them leukemia.
Okay, ma'am.
Lymphoma is when it has just involved the lymph nodes and yet to or has not involved bone marrow.
Okay, ma'am.
Okay. Leukemias arise de novo from the bone marrow, so they can spill over and then go and involve the lymph nodes. So that is why in lymphomas, lymphadenopathy is the most common presenting symptom, one of the most common presenting symptom.
Okay.
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 Do you think this child has febrile neutropenia? Because
No,
she has
ma'am.
fever, she has thrombocytopenia. You said she's dull looking in between febrile episodes. So febrile neutropenia is also an emergency, isn't it?
Yes, ma'am. Yes, ma'am.
How do you define febrile neutropenia?
It is a history of fever more than 101 degrees Celsius, then absolute neutrophil count less than 500. Then with the history of immunosuppression will be present, ma'am. With the recurrent any respiratory tract infections, pneumonias.
Focus can be anywhere, no?
Yes, ma'am. Yes, ma'am.
Focus can be anywhere. So that's history of where it started is not relevant. So you just have fever originating from, whichever anatomical site associated with neutropenia.
Yes, ma'am.
Okay. So that becomes a medical emergency, isn't it?
Yes, ma'am.
So in that scenario, you are also you will be forced to start the child on some antibiotics.
Yes, ma'am. First,
till you get your culture reports.
Yes, ma'am.
Yes.
First line drug will be ceftazidime, some most common organism, Pseudomonas, in the acute febrile neutropenia.
Yes, that's the most common organism. Yeah. These patients say it's a febrile neutropenia. What are the instructions you will give your nurse when she's drawing samples for blood culture?
First, we have to avoid the contact with the patient, ma'am, because the more prone for infection, both including attenders also, ma'am, parents also, staff nurse also, avoid unnecessary contact. Mainly maintain the aseptic precautions by unnecessary pricking, then without sterilization, avoid the unwanted touching of the IV sets, when flown, and IV drip set, ma'am, for changing.
I want to know what instructions will you give your nurse? See, you cannot treat a child without contact, isn't it? So you want to minimize the unnecessary contact. I agree. So you have worn a mask. Like now we are in the COVID generation. Now we've got used to wearing masks, and most of our nurses wear gloves before they touch patients. So for us in oncology, it's masks and gloves are a must for our nurses. So it comes very inherently to them. Okay. So when you ask the nurse to take blood samples, you tell her to draw from 2 different sites and adequate volume of blood, because the yield of bacteria from the sample is around 20%, isn't it? So you want to give an adequate quantity of blood. So what I was trying to get from you is a minimum of 5 to 10 ml blood should be drawn.
Okay, ma'am.
Otherwise, the yield will be very poor.
Okay.
So your chances of getting a positive culture decreases if you draw less blood samples. So for a pediatric culture bottle, at least 5 to 7 ml of blood should be drawn from 2 different sites.
Okay.
Okay.
So with the bone marrow, you have diagnosed acute leukemia.
Okay,
Now,
ma'am.
are you aware of any, what are the further tests that are done to know what type of leukemia it is, and any other additional tests that can help us in prognostication and all that?
We have to start the immunohistochemistry, ma'am.
Immunohistochemistry you would do on a bone marrow biopsy, but on a,
Flow cytometry
yeah.
in bone marrow aspiration.
Yes, that will tell us what type of leukemia it is.
Specific subtypes in AL.
Yeah, it's a T lymphoblastic or a B lymphoblastic, or
B cell, B cell, and T cell.
yeah, or it's an AML. You will diagnose by flow cytometry.
Okay, ma'am.
Any other tests that you would do on the bone marrow?
Specific staining can be done for with the bone marrow aspiration smear, ma'am. TDT stain and PA stain, ma'am.
That we did it in the initial peripheral smear, and now we've done a marrow and we've done flow cytometry. Marrow samples, would you like to send for anything else? Are you aware of any other tests that can be done? Just you can, I mean, not aware also, it's all right, but we do some more tests on the bone marrow. Yeah, maybe it's, but we would do some side.
Yeah, it's probably a little,
too much
for them.
Yeah, we would do a tumor karyotyping and certain translocations, which we would see whether into high risk or not standard risk. So if the child has got B lymphoblastic leukemia, and you've diagnosed, what would you tell the parents? I mean, simply, what is your understanding of a B lymphoblastic leukemia?
We have to explain the prognosis, ma'am, then availability of treatment, curable rate, and complications of chemotherapies. That's
So what do you think is the cure rate for B lymphoblastic leukemia? It's bad or good? Or which is good? B lymphoblastic leukemia, or T lymphoblastic leukemia, or acute myeloid leukemia?
B will good prognosis, ma'am. B.
B, yes, correct. Of the three, B has got a better prognosis.
Good prognosis.
And pick a number in 5 years. How many of them would be not relapsing?
Relapsing.
Disease will be cured in what is your idea? What do you think? How many out of 100? How many children could be cured? You think? You could guess the number.
85%.
Yeah, some countries have reached 90% also, though in India it is quite little lesser than that. It's got a good outcome.
Okay.
Many children can get cured and lead a near normal life and proceed on to become normal adults. So children's leukemia in that way is good. That's one of the curable cancers.
Okay.
If this were to be AML, what is your understanding? What chances does the child have?
In
It's
AML,
okay if you do not have, just a vague idea is fine. I know it's beyond your, probably your academic curriculum. So generally, ALLs do better.
yes,
If say 100 children have acute leukemia, around 70 to 75% have ALL, 25 to 30% have AML. Okay. So, and AML success rates are in the range of 65 to 70% for the good types.
Okay, ma'am.
For the high risk genotypes, we are, still yet to get to a reasonable, overall survival rates.
Okay.
Okay. So what Dr. Deepti was trying to say is when you break the bad news, isn't it? So it's not a great news for the patient. So when you break the bad news to the parents, so you got to tell them
the diagnosis.
Yes, the most probable diagnosis is, acute leukemia, and referring to a doctor who is specialized in treating such a diagnosis, and you tell them that most probably the child will do well and kind of motivate them to take treatment.
Okay.
And most important thing is what we would expect. I know, our job is most of the time made very easy. We have the diagnosis when the patient reaches us most of the time. Very rarely we find a patient who's had pancytopenia and not much information has been obtained on bone marrow or peripheral blood or multiple investigations that have been done on the child. Very rarely we end up diagnosing it in our centers. Most of the time we have the child with the diagnosis. So a lot of the times our work is easy. I understand that most the job is more on you to kind of stabilize the patient, reach to a reasonable diagnosis, and make sure that the patient is transferred in a stable state. By stable state, I mean vitals, bleeding parameters, and tumor lysis syndrome parameters. So all these have to be taken into consideration before you shift the patient to a specialized center. So these things, if you know, it's more than enough. I am not sure if your syllabus requires you to know the headings of treatment of leukemia. I'm not sure if I can ask that question to you. So, so if you know, you can tell me. If you do not know, I can.
Yes, ma'am. The total is a total duration of 2 to 2.5 years, ma'am. Started from the induction phase and the prevent the CNS complication, then consultation phase, and then maintenance phase, ma'am.
Yeah, if you know that much, it's more than enough. Yeah. So for leukemia, it's a prolonged treatment, and their success rates are very high. So most of the time, most protocols treat anywhere between 2 to 2.5 years, depending on which country you live in.
Okay.
AML is a short, high-intensive treatment. Most of the time they're in the hospital, and most of the time they need a lot of supportive care. In fact, in AML, giving chemo is very easy. Battling what comes after you give chemotherapy is very difficult.
Okay.
So it's called induction, the first course, because you want to induce remission in these patients. You want to bring whatever the hematological process that is happening to a reasonable control.
Okay.
So that reasonable control is defined by various terminologies in different protocols. So basically you want to bring the marrow back to less than 5% blasts, isn't it? So when you say leukemia, it is more than 5% blasts, isn't it?
Yes, ma'am.
Anybody can have less than 5% blasts. That is up to 5% is normal.
Okay.
So generally we describe leukemia to when the patient has anywhere more than 25% blasts. Okay, most patients have more than 25% blasts. Okay? So you want that marrow to come back into control. So you give certain chemotherapeutic agents to bring that into control. So that is inducing remission. So once you have brought the disease under control, you consolidate. So the word itself means that you consolidate what you have achieved. The next set of chemotherapy that you would give is to consolidate whatever goal you have achieved.
To increase the burden of the cell in the body.
Yes. So once you consolidate, as you said, go on to maintenance chemotherapy. That means you want to maintain that remission.
Yes. Yes, ma'am.
For a reasonable period of time, depending on the protocol that you're using. Most protocols use around total of 2 years of treatment, of which around 18 months to 2 years can be maintenance chemotherapy. So in maintenance, you give a very small dose of chemotherapy agent.
Yes, ma'am. Very low dose.
Yeah. So
includes
and to keep
methotrexate and 6 mercaptopurine.
Yes. So those are the drugs that are used to keep the dormant malignant cell in remission.
To prevent the relapse also.
Yes. Yes. So those are the goals in treatment of leukemia. Along with that, so in leukemia, other places where you can have problems is in boys. general physical examination, if this child were to be a boy, we would have expected
Testicular
you to check.
involvement.
Yes, yes. So upfront testicular involvement you should look for. Okay. And in both gender, it can also present in CSS.
CNS involvement and testicular.
Yeah. So if it was there, upfront involvement is not very
Radiation.
common. Yeah. Yeah, radiation, we have come far from radiation now. We do not use radiation anymore. Older protocols used to use radiation. We have CNS-directed chemotherapy agents, which helps us avoid radiation, because radiation itself is again a
This
mode
therapy of
of
methotrexate for CNS involvement nowadays.
yeah, intrathecal administration of methotrexate. You want to avoid radiation because that also has side effects, long-term side effects. Yes, yes. And you want to keep that tool with you in case, God forbid, the patient relapses in the future. So otherwise, if you give upfront radiation, you don't have much to treat the child with later on.
Okay.
Okay, so those will be the goals.
I think, yeah, there's a request that we allow for more questions. In the 10 minutes, I think some more panelists would like to ask some questions.
Ma'am, I'm the chairperson here, madam. I have one question in treating this child, where we actually came with low platelet count and hematuria only. So we were looking after to diagnose all this emergency medical conditions. The thing is, with 15,000 platelet count, with one transfusion, we could not control the hematuria. So is it really possible with 1 or 2 platelet transfusion, we'll be able to arrest the bleeding in such type of, because you said to stabilize the patient and send it peripheral centers, but we could not stabilize the low platelet count. Is it possible with the 1 or 2 platelet transfusions?
You want to answer that, Dr. Deepti?
Yeah, I mean, we usually give 1 unit of platelets for every 10 kilo body weight. It might increase it by 10 if it a platelet count. But hematuria might not settle immediately because there might be a clot in the bladder. So it might be ongoing. So it's all right. You transfuse and you could send. It's not that you give platelet and it would stop immediately.
Okay.
Child is clinically stable, and you could transfuse and look for other bleeding parameters, that if there are any delay, PTA, PTT or something, or fibrinogen is low, that also you could correct. And keep the child hydrated, because we don't want the clots to be there and cause any obstruction in the urinary flow. One thing we should avoid is definitely giving tranexamic acid for this thing. Keep platelet count, hydrate, and send the child. If the child has got obstruction because of a clot, sometimes we could catheterize, but that also we have to be very careful, because platelets are very low. Under platelet cover, gentle, like a feeding tube catheterization, something could be done if the child is, obstructed or the clot is causing severe pain in the urine.
We were worried whether the child will go for CNS bleeds or like ICT. Then that's why we are. Will these children go for, if the platelet count is persistent, will they go for CNS bleed, intracranial bleeds?
Generally, visceral bleeds are uncommon, sir. We see more of cutaneous and mucosal bleeds. Very rarely patients present with visceral bleeds, wet bleeds, what we call them, similar to what we see in ITP. So, so in these patients, intracranial bleeds are common in children who have high WBC counts. So more commoner in acute myeloid leukemias, because we know that myeloblasts are very sticky. They stick to each other. So they have a tendency to clog the blood vessels. They make the blood flow sluggish. And once the blood flow is sluggish, and then you have the risk of ischemia, infarct, stroke, seizures, all those complications that come. And there is a higher risk of bleeding in these patients. In patients who are in the normal range WBC count or even leukopenia, in them wet bleeds are uncommon, and in those patients you will be able to manage them with the platelet transfusion quite easily. So what I would want the audience to understand is, so in leukemia, it's a dynamic process. So we do a lot of tests. No test is one time. So if the patient has come to me now in casualty, I'm again going to run some more tests in within 4 hours, 6 hours. it's a continuous process. So no one value will be absolute for that patient. So you have transfused platelets now, you check again after 6 hours, there's no increment, you're transfusing again. So your goal is to stop systemic bleeding. So some patients will need a lot of platelets, some patients will have good increment, as soon as you transfuse. So if this child were to be ALL and I have made a quick diagnosis within 24 hours, I would start the treatment as quickly as possible. Because just transfusing platelets may not treat the thrombocytopenia in this patient. So steroids, as you know, are the cornerstone of treatment in ALL. So sometimes starting treatment will itself correct the ongoing hematological process. On the contrary, if it were to be AML M3, it becomes a completely different ball game. You will have to give cryo, FFP, sometimes twice a day, thrice a day, or as it is required. And you will be doing a lot of blood tests around the clock till you stabilize. In them again, I do not know if you know, there's a drug called ATRA, all-trans-retinoic acid. So that is the drug which has to be started quickly under the cover of steroids to bring the situation under control. So it depends on what type of leukemia you would diagnose. So if you have the diagnosis.
Yeah, we can say it's an acute presentations of leukemia, because many children present as chronic. So it's very, we have enough time to diagnose. So these are some of the conditions where there's an acute presentation of acute leukemia. Thank you.
Rajkumar, can you stop the slide sharing?
Okay, sure.
Sir, any more questions, sir? Now, it's actually excellent presentation, and I thank chairperson as well as moderators as well as postgraduates. Now I invite Dr. PRC sir to come on. Yeah.
Thank you. We had a good discussion and a very nice presentation. Of course, it's not a very typical case which we usually have of acute leukemia. There are only two clues. One was when the examination he was told about the ecchymosis. The second clue was there are two hematologists in the moderators. Other than that, I would have never guessed that during the initial history presentation, it's going to be like this. Okay, so because it's not a very common way you get it, the presentation. But of course, that's the way it is. Medicine is. Okay, nothing is 100% the same way it's going to be. For Dr. Rajkumar and friends,
yes,
thank you. You did. You got presented very confidently and very clearly, and you were able to say when you knew the answers, and you were equally clear in saying that you did not know the answers, and you let the examiners go on to explain. Okay, so that's a very good thing.
Thank you,
in
sir.
Exam also, there are certain things. Sometimes you may not be knowing all the answers. You don't have to waste your time. So that's a good way of. I do appreciate. Okay.
Thank you, sir.
Of course, that has to be less than 10% or 20%. Of course.
Okay, sure,
not
sir.
knowing the answer.
Sure, sir.
Okay. The other thing is, please don't forget that we are presenting to mostly general pediatricians.
Okay.
So please emphasize all the common aspects. See, when you are presenting an adolescent girl, you should never forget to talk about the menstrual history. Okay, there may be even something like an increased bleed there. You will never know. Okay, so you have to talk about it. Okay. And when you are talking about the examination, you have to talk about the BMI. You have to talk about the. Actually, you have to put up the growth charts.
Sure.
Your exam papers are expected to have the growth charts.
Sure.
Okay, please make it a point in every case you write in your college, include the growth chart. For a child more than 5 years to 18 years, you include the IAP chart and give it to them when they are getting discharged. Okay.
We are doing, sir, in our hospital.
As Dr. Suma was telling, something like a Fanconi you can even pick up by just doing a proper anthropometry. Okay, so you never know. Sometimes you can pick up things which will lead you one from to another. Okay.
Okay.
Please don't forget all the basic things, and also show to that the examiner that you have done it. you would have done throughout your this thing, your practice in the hospital, but you don't do it in the exam. Okay, you have to exhibit in that half an hour that you done. You touch all the basics correctly. Okay,
Okay.
that is the important thing in this training in presentation. Okay, that should come automatically. So otherwise, I really appreciate it. It's a good presentation and a very good discussion, and we are able to learn a lot of important things. And please remember, as both Dr. Suma and Dr. Deepthi were telling, all the things which a general pediatrician is expected to know, you should be thorough. Okay, like the various definitions, the investigations, because you are mainly going to stabilize the child for the bleeding and the tumor lysis, and later febrile neutropenia and diagnosing this. And most of the examiners will also ask you about immunization, okay, and they may exposed to infections. Because as general pediatricians, you are involved in further follow-up of the care, and the patients may come to you. Okay, so you should be in constant touch with the hemato-oncologist, and you should give the shared care, as it is mentioned. So you should know all about the basic things, so that you have to tell in the exam also. So these are the things the pediatrician examiner may ask you. So you will be very confident in that. Okay, at least you are able to tell the headings of the treatment. The intricacies you may not know, but at least the important things, what is done under each heading, you should be able to know. Anyway, thank you for the opportunity. I took a long time. I think as much as your presentation I spoke. Thank you so much. Okay.
Thank you, sir.
Thank you, sir. And now I invite Dr. S. Lilirasi Madam from Director ICH. Unmute, madam. Madam, unmute பண்ணிடுங்க, unmute.
Okay. Thank you, everybody. I know this is a very unusual presentation within 3 days, and you have got a leukemia. Now, you know it is leukemia, but you know you should not tell it as a first diagnosis. So you have to, it's a very difficult situation for you. So when you're telling a history and you tell, but when you examine and you have a sternal tenderness, you have an acute, now, you can boldly say, now I change my order of diagnosis. You needn't put an enteric fever first at that time. Okay, so nobody's going to penalize you because you have analyzed in your history, and when you come to examination, you have all that, the clues. Then you can change your order of presentation because you are caught as if somebody has given you a clue in the exam. That is how. But then once you have these findings, you can boldly say, my first diagnosis, I'm suspecting this. Okay, nobody's going to penalize you because then you change the order. So fine, because you, as sir said, for a general pediatrician, we know there are two good young oncologists sitting there, and we got the clue it's malignancy even seeing them. But then for you, then exam, you're going to have a general pediatrician. So you have to go on that way. And it is good, a wonderful experience. We learn a lot every week. That's a real nice thing about. And congratulations, Rajwan. And you and your colleagues should also discuss before you present, so that you three know everything about the patient. So when you get exhausted when we keep asking you 10 to 50 questions, and they can also come. So you have to have, because after it's your case in your hospital, you three should have a good, kind of understanding about this patient. So that's how it should be. Okay, and all the best. Thank you.
Thank you, ma'am.
Thank you, ma'am.
So I request Dr. Janani Shankar. Madam Janani, madam, yeah, are you there? It's not there. Okay.
Dr. Rajendran.
Yeah.
If I may say so, I congratulate Dr. Suma and Dr. Deepthi for helping the students and explaining things in a very, very nice, lucid way. So that helped us also. To be very frank, I knew that there was one boy and two girls who were the presenters. Okay. So first I thought, I didn't know that, I forgot the names. So I thought Rajkumar is the boy and you two were the two girls who are going to present. Okay. So please take it as a compliment. Okay, not any other way. Okay. So you showed that you're all well-established hemato-oncologists.
Sure, sir. Thank you, sir.
Yeah. Dr. Janani Shankar, madam? Not there. Okay. So on behalf of IAP TNSA, I thank Dr. Swaminathan sir as a chairperson, and and postgraduates from SRM Medical College. And it's a wonderful presentation by Rajkumar, and it is complemented by Dr. PRC sir. And I thank our Dr. Suma from Bangalore and Dr. Diti from CMC Vellore. And they both young pediatric oncologists, hemato-oncologists, they've done very well. And yes, it's a very difficult case, and they handle very well. And I thank one and all for this opportunity. And this is actually 40th postgraduate case presentation, and we are conducting. And hope and all the postgraduates will be benefited. I thank one and all. Thank you very much.
Thank you, sir. Thank you for giving the opportunity, sir.
Thank you.
Thank you.
Thank you and good night.
Thank you, ma'am.
Thanks,
Can
Professor
I say,
Swaminathan.
can I
Thank you,
just
sir.
say
Thank
one
you.
thing, sir?
Please, yeah, please.
I always respect, the general pediatricians who refer these cases to us. Most of the time they are stable. I just want to mention that recently in the last 1 month, I had 2 children. One was 5 years old, born to slightly elderly parents with recurrent pregnancy loss history in the family. So the child was a preterm baby at birth and had birth asphyxia, admitted in NICU, and he was under the care of a pediatrician. Of course, the child was not completely like cerebral palsy, but he had some amount of neurological deficits. The child ended up having T lymphoblastic lymphoma when the child came to us. So we have diagnosed the disease within 24 hours. That's not a problem. So then the child is malnourished with a neurological deficit. So for us, it is a huge thing to diagnose what went wrong with the parents. They've had recurrent pregnancy loss, 4 pregnancies they've lost, and this child is leukemia. So, if we had that history from the parents as to why those 3 pregnancies were lost, so again, managing this child would become easy. So we had to do an extended Q3 test on this patient, make sure there are no metabolic disorders in the patient, and rule out whatever that can be ruled out, because the time to treat leukemia is very short. Within 48 hours, you have to start treatment. So in that was a very challenging case, I thought I had in the recent past. Another child, why I was mentioning neurocutaneous markers is, this patient is 4 years old. He's still on treatment with me. So he has multiple capillary spots all over the body, has a younger sibling, doesn't have any capillary spots. Mother has 3 or 4 capillary spots, no family history of neurofibromatosis. But that was a child under a government health scheme. So I could not get any cytogenetics or any, biological tests done. If as for neurofibromatosis, stress cytogenetics to look for any bone marrow failure syndrome. So all these places, I feel the pediatrician who's referring to us matters a lot to us. So when they stabilize, they pick up all this and call us up and tell us that, this child has got all these things. I'm sending the patient to you so that the leukemia part can be taken care of. So I'm really thankful to all the pediatricians who refer patients to us, believing in us. Most of the job is done for us, as I mentioned. We just have to stabilize and treat the child. That's most of the time our job. So I sincerely thank all of you.
Yeah, thank you, Dr. Asma, for your sincere effort, and thank you, Kitty. I think they are still handling a lot of VLL cases in CMC Vellore. And thank you, Ananda. Thank you.
Thank you, sir. Thank you.